Hey everybody, Walter from the future here. I just realized I went through the whole lecture and I didn't give any kind of content warning. Since this is a lecture about trauma, I want everybody to know we're going to be talking about trauma. So that means sexual assault, rape, war, violence, all sorts of things are going to be discussed in this lecture to give you a heads up. So that's your content warning for the lecture. Moving forward, some of the topics that we're talking about might be more personal, just like what I said. If you feel like you need to do some self-care before you watch this lecture or the other lectures, do that. The syllabus is the content warning, so just keep that in mind. All right, everybody. Hey, hello class. This is going to be our week 7 lecture. We're going to be going over trauma. This is going to be a 2-part series. So week 8, we're going to go over trauma again. For week 7, we're going to do acute stress disorder and post-traumatic stress disorder. And then when we do week 8, we're going to do dissociative identity disorder. So let's get started here. We're going to talk about PTSD and acute stress disorder. So we're going to start right over here. What is trauma? With prevalence, with the symptoms, etiology, and treatment. But before we get started, let's do some quick review. So what do you think might lead to the onset of PTSD? PTSD being post-traumatic stress disorder, being robbed at gunpoint, witnessing the murder of a loved one, living in New Orleans during Hurricane Katrina, being a firefighter, or any of these can cause PTSD. So A, B, C, D, E. Okay, which one do you think it is? Any of these can cause PTSD. So let's talk a little bit about the history of PTSD. So historically, people have thought of PTSD in a variety of different ways. Railway spine came around in the 19th century. So this had to do with what happened around train accidents. People who survived from these accidents had this fear, this apprehension about trains, and they often had these vivid experiences or reimaginings of being in that accident, and they were changed moving forward. And so this is why they called it railway spine. So soldier's heart, how doctors and scientists thought about the effects of the Civil War. So post-Civil War, there's a lot of veterans returning that had changed. They were different. They had different mentalities. They weren't the same person. So they went off to war and they came back and they had been changed by the war. And so this was thought of as soldier's heart. In World War I, we had shell shock. Shell shock occurred when the big artillery was blowing up around the trenches, death and destruction. This did something to you in the moment, but also when you came home. We go to World War II, where we had combat stress reaction, also known as battle fatigue. So this was actually very common after World War II. People during battle would be weary and exhausted, and when they came home, they suffered severe adverse effects. And so as time went on, scientists and clinicians, they started to refer to these kinds of disorders as war neuroses. So these war neuroses, these are the earliest conceptualizations of post-traumatic stress disorder. This term encompassed a variety of different disorders that were seen as being caused by war. Around 1980, that's when the DSM-3 introduced the post-traumatic stress disorder as a psychiatric diagnosis. So DSM-3, PTSD. That's how you remember that. So let's talk about what a traumatic event is. A traumatic event is any event that involves actual or threatened death, serious injury, sexual violence, in a variety of different ways. So you can think about somebody directly experiencing the event, somebody witnessing the event, somebody learning that an event occurred to a close friend or family member. And you could also think about repeated exposure to the details of traumatic events. So this is people like first responders, clinicians, medical doctors. Being repeatedly exposed to these kind of traumatic events can cause PTSD. In light of recent events, we can think about how certain kinds of repeated exposure to trauma on the news or the internet or in our neighborhoods can lead to PTSD. So hearing about unarmed Black people being killed by police officers, this can lead to PTSD. This is very traumatic. You probably have a family member who was involved in a similar situation, or maybe you yourself was involved in some situation like that. So repeated exposure, these kind of traumas can lead to PTSD. So what is not trauma? Let's talk about that for a second. A lot of people refer to distressing events as traumatic events. And there's a difference between distress and trauma. And we see right here that is an event that involves actual or threatened death, serious injury, or sexual violence. So let's go ahead, and we have a video here. So I'm going to go ahead and pop this on here for you. And then while you're watching this video, I want you to think about the trauma discussed in this video. I want you to think about the ways that it affects people. Is it psychological? Is it physiological? Look at the trauma, see what you think about.
As the 15th anniversary of 9/11 approaches, a new study says that beyond physical health problems, 9/11 first responders may also suffer from PTSD. RT's Trinity Chavez has the story.
It's been 15 years since the terrorist attacks happened on September 11th, 2001. Nearly 3,000 people were killed, and tens of thousands of people across the country continue to feel the effects on their health. And now, a new study published by the Journal of Alzheimer's and Dementia confirms the correlation between post-traumatic stress disorder and cognitive impairment to the first responders of 9/11. During the World Trade Center attacks, responders who helped search, rescue, and recover victims suffered from a multitude of traumatic and toxic exposures. Daniel Moynihan is one of the first responders who continue to suffer to this day.
I've got a number of physical impairments, though I'm very lucky because I don't have cancer. I've lost my ability to smell, 2 different lung issues, 3 different neurological issues. I'm now deaf on the right side, and not only physical issues, but mental issues. There's PTSD.
Come on in! And he's not the only one. According to the study, 1/5 of these individuals developed PTSD following the attacks, and that number continues to grow. According to the research, in a population of more than 800 World Trade Center responders, almost 13% had scores indicative of cognitive impairment. Over 1% had scores suggesting possible dementia. The study also found that post-traumatic stress disorder and medical depressive disorder were associated with CI, as well as re-experiencing symptoms such as flashbacks and nightmares.
My partner's been telling me for years, write things down. Honey, get a pad. You need to write things down because you're forgetting things.
Sean Clouston, the author of the study and assistant professor at the Stony Brook University, says that those are the very symptoms of cognitive impairment and possibly early dementia.
PTSD is very well understood in this cohort. It's really this sort of early cognitive impairment and ultimately dementia that we're really starting to try and understand with this study. It builds on work from the veterans. So the veterans have shown that PTSD is a good predictor of Alzheimer's disease. We actually excluded anyone that reported any type of head injury.
In July 2002, the Centers for Disease Control initiated a monitoring and treatment program for the World Trade Center responders, and since then, more than 33,000 responders have enrolled in the health program. The entire World Trade Center health program has approximately 75,000 members. In addition to those who have cancer, 12,000 of those people have been diagnosed with mental-related issues related to the attacks. As of July 2016, there were 64,198 responders and 9,770 survivors enrolled.
The thought of where I'd be actually kind of scares me because the prospects of where I'd be are, wow, it's kind of it's a dangerous and scary thought.
The World Trade Center Registry, who is run by the New York Department of Health, is expected to release a full report in September detailing more health issues of the survivors linked to the attacks. Reporting in New York, Trinity Chavez, RT.
So after watching that video, what did you think about it, right? What do you think about the trauma? What do you think about, some of the side effects or some of the experiences of PTSD, the cognitive decline, some of the health issues, things like that. So the traumatic event itself can lead to a variety of outcomes, PTSD being one of them. And so what do you think? Do you think that every time someone encounters trauma, that they develop PTSD? Do you think that there's a sufficient number of traumas you have to encounter to get PTSD? Do you feel like some people are more predisposed to PTSD than others? Think about it to yourself, and we can talk about that during office hours if you would like. I put some examples of traumatic stressors. So we have rape, sexual abuse, domestic violence, violent crimes, war, we have bombings, we have being involved in plane or car crashes, train crashes, natural disasters. This photo right here, this is a photo of Tent City, Arizona. This is where I spent the summer of 2011 for my DUI. Some people might describe being in jail as traumatic. The incarceration part could be traumatic, but also there's a lot of different events that happen while you're in jail that could definitely be considered traumatic. So the experience of traumatic events is actually quite common. Former definitions of trauma actually included the qualifier outside of the range of normal human experience. And this was changed because traumatic events are very natural. I mean, unfortunately, people experience traumatic events all the time, especially when you're thinking about things like people living in different neighborhoods, people who are coming back from war deployments, and sexual assault survivors. Trauma is very common. It's a common part of human experience. So there's a 40 to 90% lifetime prevalence of traumatic events, but the formation of PTSD is still relatively rare. According to recent studies, lifetime prevalence of PTSD is about 6.8%. And if you think about a 12-month prevalence, you're looking at about 3.5%. And research suggests that women are as much as twice as likely to develop PTSD compared to males. Okay, so children can suffer from PTSD as well. So when we look at trauma and abuse, children that are abused by parents or loved ones are actually at a greater risk of developing PTSD than those that are abused by strangers or peers. So there's a 20 to 40% chance, depending on which research you're looking at, that a child that experiences trauma might develop PTSD. Ethnic minorities are at a great increased risk. This could be due to more difficult living conditions due to socioeconomic status or other kinds of racialized traumas that are involved. So combat veterans have like a 30% prevalence rate of PTSD. So the RAND Corporation and Center for Military Policy Research did a study in 2008, and they found that about 15% of Vietnam War vets have PTSD, but only about 13.8% of Iraqi War veterans had a lower rate of PTSD than Vietnam War veterans. All right, so when it comes to comorbidity with PTSD, we can see that people who have PTSD also suffer from a variety of other psychiatric disorders. We have depression, anxiety, substance abuse. Why do you think that individuals who have PTSD might also suffer from depression? What is it about the trauma? What is it about their situation and the experiences of PTSD that might lead to that depression? Think about the anxiety. So what is anxiety? Persistent worry. So think about how PTSD might interact with that. Also substance abuse. What's happening with substance abuse there? With people self-medicating, trying to escape, trying to get out of this feeling of this trauma, of these recurrent thoughts of the trauma. So individuals with PTSD are 80% more likely than those without PTSD to have symptoms that meet criteria for at least one other mental disorder. This includes depressive disorders, anxiety disorders, bipolar disorders, or substance use disorders. So with PTSD, there's also increased thoughts of death, and there's actually a greater risk for suicide. So 33% of sexual assault survivors had thoughts of suicide, and 13% had made a suicide attempt. This is based on a study that was conducted back in 1992. Among returning military and combat personnel, there is a 48% co-occurrence of mild traumatic brain injury with PTSD. So although most young children with PTSD also have at least one other diagnosis, the patterns of comorbidity are different than in adults. So when you think about children, oppositional defiant disorder and separation anxiety disorder are the most predominant co-occurring disorders when it comes to PTSD. And those stats are from studies done in 2005 and 2006. And finally, there is considerable comorbidity between PTSD and major neurocognitive disorder. And there's also some overlapping symptoms between these disorders. So that means if we're looking at PTSD and neurocognitive disorder, you'll see there's a lot in common. And we saw that in the video. I was giving examples of some of the cognitive decline experienced by individuals who went through 9/11. This study was conducted in 2010. So right over here, we have a little video about PTSD. Let's go ahead and watch it. And while you're watching this, think about some of the things that we talked about in the prior slide and how they're present in this video.
It's like living with a leash on a little bit. You can do some stuff, but every now and then you remember that it's there.
I was living in Japan during the earthquake in 2011.
A few weeks and months of political unrest while I was living overseas. We lived with bags by the door ready to go in case we needed to get out.
I found out in 2008 I had PTSD, complex PTSD, but I think the diagnosis should have probably been made when I was 14 years old.
I was raped, and as a result, I live with PTSD.
The civil war in Lebanon broke out in 1975. I was only 17 years old. I lived through that for about 12 years.
As it kind of sunk in, I started to feel really guilty because I had always associated PTSD with people who had been to war, and I just didn't think I deserved it. The PTSD triggers, they ambush you. You don't know when it's gonna come. It's sort of the unknown. Every day you wake up and you don't know if you're going to have a trigger today.
I was at a movie, and there's a part where this woman got trapped in a car. I had a serious panic attack.
There was a song that was talking about shooting and armed robbery, and just hearing that song, that was all it took.
Something happened when I was 13, and when my trigger happens, in that moment, I am 13.
Usually the sounds of jet planes overhead would trigger off the memory for me of those days. It would make me feel weak in the legs, and my memory will go back to that time trying to look after my children when they were little and protect them. Yeah, all I had to do is hear a jet plane, and that's where my mind will go.
At times, it has literally felt like I'm dying. You feel like you're never gonna get past this. One of the things that's helped me a lot was group therapy. This happens to more people than you think.
Start to have a conversation with this thing that you have.
I did counseling for 2 years in college, and it felt like that got my life into a pretty manageable place.
I am trying to build up the courage to attend a support group.
I would have these days where you're just like, there's nothing I can do to do anything that you're supposed to do. In group therapy, someone called it a lost day. It's such a simple thing, but putting the words lost day to those days helped me overcome.
And I think accepting that is really important, and just being like, it's okay to freak out and just be like, oh, this is scary, because it's scary.
And don't ever tell them to get over it, because it's extremely painful.
It takes practice, and it takes patience, and it takes faith. You have to know that the fact that you've been through something so traumatic and you're here, you are much stronger than you think you are.
Don't feel guilty when you have a good day.
Give yourself time to heal.
You can't judge yourself for it.
It'll never be the same, but it can get better, and it's worth whatever it's gonna take. You can have a better life.
There is a light at the end of the tunnel. You just got to find the right thing that works for you.
And getting help is not a sign of weakness. It takes a lot of strength and a lot of courage, and you deserve the happiness that comes with getting better.
My name is Kate.
My name is Tammy.
My name is Kirk, and I live with PTSD.
All right, so watching that video about PTSD, what kind of things did you pick up on? So you have the different triggers, you have the different things that happen to people. Also, it presents itself in a different way. So everybody's PTSD looks differently. So some people might ask, well, does PTSD always have this? Does it always have that? Well, it varies. And we'll see that as we go over some of these symptoms here and the criterion that you would need in order to give a diagnosis. So one of the things that I want to point out in that video that you saw one of the individuals expressing the fact that telling someone to get over their PTSD, that's not something that you want to say. So you don't want to be the kind of person who's diminishing or discounting somebody's psychopathology. So like I talked about with depression, I've talked about with bipolar disorder, and anxiety. Just telling someone to stop something doesn't actually help them as much as walking them through their disorder. And we'll get into that when we go over treatment. Well, right over here, we have the PTSD diagnostic criteria from the DSM-5. The central feature of PTSD is the trauma. Criterion A for PTSD would be the exposure to a recent trauma involving death, threatened death, actual or threatened serious injury, or actual or threatened sexual violence in the following of ways. This could be direct exposure. This could be witnessing the trauma. This could be learning that a relative or a close friend has been exposed to a trauma. This could also be indirect exposure to aversive details of the trauma, usually in the course of professional duties. So this is what we're talking about with first responders, medics, doctors, reporters, things of that nature. And also, you're going to, in addition to criterion A, you're going to need to have a certain number of symptoms in each of these categories, 4 categories. So we have intrusion, avoidance, negative alterations in the cognition mood, and alterations in arousal and reactivity. So you're going to need to have 1 or more intrusion, 1 or more avoidance, 2 or more cognition mood, 2 or more arousal reactivity symptoms in order to achieve a diagnosis of PTSD. So as you see, we have intrusion, avoidance, cognition mood, and arousal. So intrusion, this is going to be criterion B. Avoidance is criterion C. Cognition mood is criterion D. And arousal is criterion E. So we're going to go over criterion B and C first. So criterion B is going to be intrusion. So you need at least 1 of these to receive a diagnosis for PTSD. For intrusion, the traumatic event is going to be persistently re-experienced in the following ways through either intrusive thoughts, nightmares, flashbacks, emotional distress after exposure to traumatic reminders, physical reactivity after exposure to traumatic reminders. So you're going to need to re-experience that traumatic event in one of those ways. Now let's look at criterion C. This is going to be avoidance, and you need 1 or more of these in order to receive a diagnosis for PTSD. So this is going to be the avoidance of trauma-related stimuli after the trauma in one of the following ways. So this is going to be avoiding trauma-related thoughts or feelings, or avoiding trauma-related reminders. So this could be numbing yourself emotionally or doing things that might distract yourself from re-experiencing the trauma. So this could be avoiding locations, avoiding people, or other kinds of settings associated with the trauma. And then we're talking about avoiding these thoughts. This is you trying to distract yourself or self-medicate. This is where some of the comorbidity with substance abuse might come in. So cognition mood is criterion D. You're going to need at least 2 or more of these in order to receive a diagnosis for PTSD. And this is going to be negative thoughts or feelings that began or worsened after the trauma in the following ways. So inability to recall key features of the trauma, overly negative thoughts or assumptions about oneself or the world, exaggerated blame of self or others for causing the trauma, negative affect, decreased interest in activities, feelings of isolation, difficulty experiencing positive affect. Criterion E is going to be arousal. You're going to need 2 or more of these in order to receive a diagnosis of PTSD. And this is going to be trauma-related arousal and reactivity that began or worsened after the trauma. You need irritability or aggression, risky or disruptive behavior, hypervigilance, heightened startle reaction, difficulty concentrating, difficulty sleeping. So just to summarize this real quick here, there has to be some sort of exposure to a trauma. You need at least 1 of the intrusion or avoidance symptoms and at least 2 of the cognition or arousal symptoms. And these symptoms must be present more often than not, for more days than not, for a minimum of 1 month in order to receive a diagnosis of PTSD. All right, so right over here we have some quick review. So Shayna lived in New York City at the time of 9/11, and she was walking to work when she witnessed the plane crash into the Twin Towers. 18 years later, she still experiences flashbacks of the event, and she feels like it's happening all over again. This is an example of what type of PTSD symptom: intrusion, avoidance, cognition mood, arousal, none of the above. Let's take a look right here. There we go. This is an example of intrusion. So she's having a flashback, and now she's feeling like the trauma is happening all over again. That is an intrusive thought being injected into her mind due to the trauma. Here's some more review for you. So which of the following is an example of cognition mood criterion for PTSD? Someone having difficulty staying asleep following a traumatic event. Someone is unable to recall events leading up to and following a mass shooting. On Facebook, someone blocks all the people they associate with their sexual assault because these people are reminders of the event. Someone who has been through an earthquake feels like it is happening again in that moment when it is actually not. And someone who received a venti with almond milk instead of skim at Starbucks. So think about it for a second. There we go. It's going to be B. Someone is unable to recall events leading up to and following a mass shooting. So this is, once again, memory loss, the ability to recall details. This is cognition. What is cognition? That's you thinking. Acute stress disorder is very similar to PTSD, but it only lasts for a brief amount of time. So there's actually increasing data that early intervention into PTSD can actually lead to better outcomes. So when this first started, this early intervention hypothesis started, individuals thought that the earlier that you intervened, the better the outcomes would be. The intervention of debriefing was conceptualized. So with debriefing, individuals would describe their trauma in a safe environment within 24 hours of the trauma occurring. And this actually turned out not to be a good idea. It was actually very detrimental to the clients. So researchers thought that, well, if we can't intervene right away, what needs to happen first? So they conceptualized that the wound, the trauma, and that wound had to start to heal or scab in order for new information to form. This kind of intervention of debriefing is known as an iatrogenic process. So iatrogenesis is when the treatment actually worsens or causes the disorder. So iatrogenesis. And so this is something that we don't do anymore. So that's that quick intervention within 24 hours for someone who experienced a trauma. As you can imagine, the type of traumas that people experience in life, this is not going to be helpful for them. Acute stress disorder, it was added in DSM-4. So with the addition of acute stress disorder into the DSM, victims are able to receive the help that they need earlier on. So the likelihood of developing PTSD at a later time is actually greater if victims of trauma are experiencing very strong arousal and emotional numbing following that trauma. With acute stress disorder, the goal is to try to identify people who are at the greatest risk of developing PTSD anytime between like 3 days and a month after that trauma. These are going to be the similar number of symptoms to PTSD, but acute stress disorder does not last for more than 1 month. So this is a brief disorder. So you need to wait about 3 days before you can assess for this to give that wound time to scab over, to start healing, so that way you can start processing new information up into a month after the event. Now, if the symptoms go away before a month comes, you don't have acute stress disorder, you don't have PTSD, you've been able to help the individual recover earlier. They're probably still going to have distress and impairment and other kinds of comorbid diagnoses, but there's a way for you to get in there and then help them process through the PTSD symptoms before it gets too severe. Now, after the 4 weeks has passed, or after that 30-day period, if the individual still exhibits symptoms of PTSD, then they're going to receive a diagnosis of full-blown PTSD. So a way to think about this is that acute stress disorder, it is like a short duration PTSD. So if this duration of symptoms, this goes past the 4-week period, you're going to have full-blown PTSD. So here's some review here for you. So which of the following is an example of an intrusion symptom of post-traumatic stress disorder? Is it persistent and exaggerated negative beliefs or expectations about oneself, others, or the world? Is it dissociative reactions where the individual feels or acts as if the traumatic event is reoccurring? Is it an exaggerated startle response? Is it distorted cognitions about the course or about the cause or consequences of the traumatic event that leads an individual to blame themselves or others? Or is it the indignation of suffering through the middle of season 2 of You on Netflix? There we go. The answer is B. Intrusion symptoms, the best definition there would be dissociative reactions where the individual feels or acts as if the trauma were reoccurring right now. So which of the following would be an example of effortful avoidance? Would it be an individual experiencing recurrent, distressing dreams related to a car accident they experienced? Would it be an individual having problems concentrating at work following a car accident? Would it be a person experiencing distressing memories of the car accident? Would it be a person distracting themselves from thinking about the car accident by attempting to suppress memories of it? Would it be canceling Disney Plus after realizing that Baby Yoda was a Sith Lord all along? It'd be D, a person distracting themselves from thinking about the car accident by attempting to suppress memories of it. Effortful avoidance. All right, so we have a little video right here. I'm gonna go ahead and put it on for you. And then after the video's over, we'll come back and talk about it together.
How many of you know people that have been injured or have died because of gang violence who are your age or who are kids?
This happened like a few weeks ago.
What happened?
They ran up to him, shot him 7 times in the back, shot his homie in the leg, and then shot him in the head.
It's just a normal day. It's like everyday life, and I know that's sad, but after a while you just get used to it.
So you were 7 years old when you were shot?
I was 7. You just gotta be like, dang, that's sad. You can't be like, wow, wow, wow. Like, it's too many wows.
2 weeks ago, we had about 6 shootings in one day. I mean, it was all starting at 10 o'clock in the morning. I mean, you hearing somebody take their last breath? That's a sound that never leaves you. I just want the community to look like when people forget about it. This is how it became Death Alley.
We're in South Central LA in an area that's been called Death Alley by the community because in the past 7 years there have been over 100 homicides in this neighborhood alone. People are being affected by the violence in this area in a very serious way. Most people associate post-traumatic stress disorder, PTSD, with American troops returning home from war. But when you look at communities like this, they're suffering from the same thing. Experts say it's an epidemic and that up to 40% of urban poor in America are dealing with PTSD.
South Central's South Vermont Avenue. It's the blood-soaked battlefield for at least 6 gangs that claim the area as their own. It's called Death Alley because it has one of the highest homicide rates in Los Angeles. And smack in the middle of it is Soledad Enrichment Action, or SEA.
And you hear the metal detector?
A charter high school serving the neighborhood's high-risk kids.
This community that we're in is very rough. A lot of shootings, a lot of stabbings, a lot of drugs. It's very disenfranchised.
Eric Jones is a counselor here. His job is to help identify and connect with students who are suffering from a variety of problems, including PTSD.
Let me give you a quick example. Say you're at a party and a balloon pops, people duck. They duck because they're used to hearing gunshots. And to me, my personal experience about that is post-traumatic stress disorder.
He's also a former gang member, so he's able to relate to a lot of what they're going through.
What we're curious about is the kind of violence that you see and you come from. So my first question to everyone, you guys could just raise your hands, is how many of you have known someone that's been involved in a shooting?
You're not gonna go to jail, you're all right.
Okay. And how many people have seen someone get shot?
Up close?
My mom's brother was affiliated with gang members. He wasn't a gang member. And he was walking down the street with my dad's brother and he got shot in the back with a shotgun.
I was like with my brother, it was like 5 or 6. I don't know, we used to go to the park all the time. And it was just these gangbangers. They came and then like they just started shooting. The dude was sitting right there and then it was like, we was all standing right there like we was trying to run. And then the dude just shot the other boy. He was like probably like 15. He shot him in the back of the head. He was just laid out right there. And then we just all ran. Like,
Do you ever have nightmares or think about that?
I can still see it sometimes.
That's pretty traumatic. You know, you standing next to somebody and they just get hit like that. Is anybody still affected by that? Or are you guys just kind of numb to that? Like, you know what? It happens. Okay, I'm glad it didn't happen to me. I don't know, I could be wrong, but it seemed like you guys not that traumatic to you, like it's not really affecting me, or it's like it's something I'm keeping it out of my mind so it won't mess me up.
It's like everyday life. That's the type of environment we're in. I still think it's wrong. Like at the end of the day, we're gonna feel it because we're human. But after a while, it just get like another person died, and like it's regular. It's like you adapt.
Our students have witnessed boys and girls like 3 and 4 and 5 years old being killed right in front of them, right on their streets.
Father Stan Bosch is a Catholic priest, psychotherapist, and director of SAYA's gang intervention program.
Come on, boy.
And he says many of his students show the classic symptoms of PTSD: numbness, sleeplessness, traumatic flashbacks, and a constant feeling of anxiety.
The adrenaline that's flowing, the cortisol that's flowing, the fight, flight, or freeze kind of reactions from our reptilian brain are operative all day long, really. And you see it in our classrooms, you see it out on the basketball court, you see it on the street.
Someone looks at these kids and they're like, oh, they're angry, or they're violent, or they're not interested in learning. Do you feel that some of the issues that these kids are accused of are in fact related to or are PTSD?
I believe that those kinds of characteristics are the symptoms of something deeper, of a deeper pain or wound. Why is somebody restless in a classroom and can't concentrate? There's all sorts of dynamics that are happening neurologically with that student or that youth. There's all sorts of things happening in the emotional state of one's body. The incapacity to find words for what I'm feeling inside has people reacting in violent ways.
Research by the US Centers for Disease Control and Prevention found more inner-city children suffer from PTSD than soldiers returning from war. And in communities with high rates of sufferers, it can become a serious public health issue. People are on edge, and one accidental bump, one wrong look, the color of the t-shirt you wear, can spark a new wave of violence.
Let's roll. I ain't gonna mean that roll, let's groove.
We left SAYA guided by Kevin Twin Orange. He's also a former gang member now working to prevent violence.
Me and my team, we stand out here and try to watch the temperature.
Right now, he's making sure students make it out of school and away from Death Alley safely.
When these kids step outside of school, what are the risks they're taking?
But first, of them getting killed and them getting robbed. Them two right there. You know, normally it would be droves of people just hanging out when they get out of school. So now we make them leave so they want to stand on the corners and be targets for somebody to come through and shoot them.
As a member of the Hoover's gang, Twin managed to survive the bad old days of LA's gang wars in the 1980s and 90s. But after being shot 8 times in 2006, he dedicated his life to ending the cycle of gang violence that continues even today. But to do that, he's had to come to terms with his own psychological wounds.
I've seen everything, you know what I mean? I done seen best friends die in front of me. You know, I done seen people get killed, people hurt, beat. I done seen it all. You know, so there's nothing I didn't see. I seen it all.
And how did that affect you? Like,
it made me numb. It made me numb to everything. You know what I mean? It made me numb to everything to where I was like, this was the norm. When you don't know no better, you know, you think it's normal. And that's how some of the kids get involved with it. They think it's normal, but it's not. We was the one making things the way they were. So we was writing the book along with our lifestyle. So we didn't know. But now we know where we can go back and tell them what they doing is wrong and why it's wrong. But we the one put it like that.
could you describe some of the symptoms of the violence that you've seen, what people would probably call PTSD?
I mean, you hearing somebody take their last breath? That's a sound that never leave you. I mean, that sound, first time I heard it, it's just like I heard it yesterday. Because it's a sound you never forget.
Most afternoons, Twin drives around Death Alley and surrounding neighborhoods, sniffing out and diffusing gang tensions. Today, the streets are empty. A spate of shootings the week before has kept everyone inside.
And as you can see, there's not no kids hanging out on the streets. They getting where they have to go, because I guess these last shootings that occurred, they kind of like stayed on their mind, like, man, I don't want to die today.
Tell me a little bit about the behavior or the attitude of kids who've seen shootings or who've seen violence.
People, they so used to the shootings, ambulance, helicopters, and just candles on every corner, you know? They think that's the norm because that's what they was raised and brought up in. They don't know nothing different than that. That's when you know you suffer from post-traumatic stress disorder. When stuff like that don't bother you like it's the norm, it's like, no, it's not normal.
Have you ever lost a loved one to gang violence?
Yeah, I lost hundreds of them, you know? And but the one that hurt it the most was my twin brother. I lost 4 or 5 years ago, him and my little cousin. We was at a candlelight vigil. A young man came in there and shot both of them. He shot 3 of them, but my twin brother and my cousin passed away.
Twin took us to the site of their killing.
That's where it was at. He got killed right here. See, my buddy Greg, he got killed right here. And we was standing over here. My brother was over here. I guess the guy came around, what's up now? And did his shooting, you know, and got on. You know, that's how quick things can happen.
So you were here for someone who got killed right here.
Yeah.
And while you were trying to, you know, have a vigil for that person, that's where you lost your own brother.
Yeah, my little cousin. My little cousin too, Joe. He got killed also. So that was a double whammy, you know. I'm glad I'm at a better place right now. You know, and probably before that happened, I was in a better place. Because, you know, if it would have happened years before then, I probably wouldn't be standing here. I know I wouldn't be standing there talking to you.
Why?
What he did, I would have did the same thing. You know, I would have kept that cycle going.
That's exactly what worries the staff at Manual Arts High School, in another part of South Central.
Just more recently, we've had 2 students this year who've died as a result of murder. And our kids struggle with that on a daily basis.
The latest was a 19-year-old senior named Eric Martinez. He was shot dead in early March, and counselor Gustavo Sagredo has been working double duty to help students deal with the crisis.
How many of your students deal with trauma and symptoms of PTSD?
So the rest of that video is going to be on Compass under the study video section. So if you want to continue watching the rest of that video, you can. We're going to go ahead and continue with our lecture here. So let's talk about etiology. So what does etiology mean? The causes. So we were talking about before how with other psychological disorders, like we have different theories and ideas about what might cause them, but the exact cause is not necessarily known. However, when it comes to PTSD and acute stress disorder, there is a known cause, and that cause is the experience or the exposure to trauma. And this is actually included in the diagnostic criteria. So there must be some kind of exposure to a traumatic event in order to receive a diagnosis of PTSD or acute stress disorder. It's also important to remember that just because you've experienced a trauma doesn't mean you're going to develop PTSD or develop acute stress disorder. So there's a lot of other factors that are involved when it comes to the development of PTSD. So you might think of like the social environment, you might think about a variety of biological factors, and even temperament, other kinds of personality traits that could put somebody at a greater risk of developing PTSD. So if you have a strong social support system, this will decrease the likelihood that you will develop PTSD after experiencing a trauma. So for example, when we're looking at victims of sexual assault, victim blaming increases the symptoms of PTSD as opposed to having a supportive environment. There's also some biological factors involved with the risk for PTSD. Look at monozygotic twins. If there is a high concordance rate in exposure to war, then there's going to be higher rates of PTSD compared to fraternal twins with a high concordance and exposure to war. So there seems to be some kind of biological component, some kind of genetic component for PTSD. Also, if you look at individuals who have a history of mental illness, also individuals who are more easily anxious and upset than others, these individuals might have a higher risk for developing PTSD. But when it comes to trauma, the most likely outcome after experiencing a trauma is resiliency. So that is, you experience a trauma, it troubles you for a bit, but over a while, you're able to develop like a thick skin and then start to deal with and move on from the trauma without developing PTSD. However, that is not to say that you'll be immune to future trauma. So people who experience more severe, more chronic traumas that directly affect them are more likely to develop PTSD. So when we're looking at traumatic factors that might lead to PTSD, we want to take a look at the severity, the duration, and the proximity of the trauma. So for severity, how severe is this trauma? What happened? What's the magnitude of this trauma? The duration, how long is this going on for? And the proximity, how close was the individual to what's going on? So for example, if we're talking about a bad breakup is not necessarily a traumatic event, but a bad breakup can be a traumatic event if it's depending on the severity, the duration, and the proximity to all these different issues going on. So the idea behind the PTSD threshold model is that eventually everybody has a breaking point, and any person can develop PTSD when exposed to a sufficiently intense trauma. So what we're looking at here is we're trying to see over time when encountering multiple separate traumas, right? Whereas that particular trauma or those traumas by themselves did not meet the criteria for PTSD, but how there's like this cumulative effect of trauma, this almost erosive process involved with repeated exposures to trauma, where these cumulative symptoms build up, and then you might be able to diagnose PTSD at a certain point in time. So for example, in that video that we saw, we have this chronic environment, there's a lot of repeated traumas, and that Death Alley, the murder alley, that neighborhood they were talking about. So you can experience one trauma and not have PTSD, but over time, the repeated experiences of trauma might lead you to developing PTSD. Out of the different traumas we were talking about, natural disasters have the lowest rates of PTSD compared to other traumas. So now let's talk about the treatment of PTSD. So for persons suffering from PTSD, one of the most important parts about treating them is trying to construct a new narrative about their lives that integrates the traumatic experience into it. So it's actually very critical when treating PTSD to be able to accept at some level what has happened to you and move on from it. Now, remember when I was talking about before, watching that video, where when someone encounters a trauma or has PTSD, it is not sufficient to tell them to move on from the trauma? That is because there is a process of integrating that trauma into their identity, accepting what has happened, and then being able to move on from it. So you're not negating that the trauma happened. You're not saying the trauma didn't happen. You're not saying it wasn't traumatic. You're not saying that all your feelings were invalid. You're saying that at this point in time, you're going to reintegrate this trauma into your conceptualization of who you are as a person and move along. It doesn't mean that the trauma is okay. It doesn't mean the person who traumatized you is okay. It doesn't mean that that this trauma is not a real thing. The trauma is a real thing. The people who traumatized you are responsible for what they've done, but we need to try to figure out a way to help you to continue on with your life, to live a full life. So the ways we do this are through the different kinds of tenets of a good therapeutic relationship when it comes to PTSD treatment. So you're going to need to have trust, a good therapeutic alliance with your clinician. You're going to need to be able to educate your clients about different skills of coping with their trauma. You could also need some stress management training. Stress management means you need to work with your clients to help them to understand adaptive ways of managing their stress, that stress is a normal part of life, and there are ways to cope with it and to deal with it. And also, we need to go through almost like the fear hierarchy, the exposure therapy, to try to re-experience and reintegrate the traumatic event, the traumatic situations into their lives and their self-schemas. That way they can accept what's happened to them, process that information, no longer avoid it, no longer try to self-medicate, reintegrate that into their experience and move on from it. So right over here, we have a form of PTSD treatment called stress inoculation training. This is a form of cognitive behavioral therapy, CBT. And this is where the client is going to be taught how to manage their stress and anxiety through relaxation, role-playing, cognitive restructuring, and assertiveness exercises. So the idea here is to help patients prepare themselves in advance to handle stressful events with a minimum amount of discomfort and upset. So clients are going to be educated about the nature and the impact of stress, the role of appraisal processes. So this is going to be like, is this a stressful event? And what kind of resources can I use, or what kind of resources do I have to manage this stress, and other kinds of coping mechanisms. Now, the clients are going to practice coping with these different stressors through a 4-phase program. So right over here, phase 1 is going to entail identifying the reactions to stress and the effects on functioning and psychological well-being. Phase 2 is going to be learning relaxation and self-regulation techniques. Phase 3 is going to consist of learning coping self-statements. So these kind of coping self-statements are going to be, I can handle this, I can do this, I have these resources, I have this ability to get through this, this is not going to hurt me, things of that nature. And phase 4 is going to be an assisted progression through a series of increasingly stressful situations. This is going to involve imaginary, video, role-playing, and real-life situations where an individual is going to be reintroduced to the traumatic stressor and be able to cope with the original stress-inducing situation or event. Stress inoculation training is based on a theory that this exposure to these moderately stressful events is going to build an individual's coping resources, and that coping resources is going to lead to their adaptation to these events. And this is going to promote resiliency and reduce future stress. So right over here, we have two more PTSD treatments. We have prolonged exposure therapy. So prolonged exposure is going to be a specific type of cognitive behavioral therapy that teaches individuals to gradually approach trauma-related memories, feelings, and situations. So prolonged exposure therapy is going to involve 3 main components. We have psychoeducation. So this is going to be education about common reactions to trauma and the cause of chronic post-traumatic difficulties. We're going to have imaginal exposure. So this is going to be repeated recounting of the traumatic memory. So like emotional reliving of the event. So the patient's going to be describing the event in detail in like present tense, being guided by the therapist. So together, the patient and the therapist are going to discuss and process the emotion raised by the imaginal exposure in session. The patient is going to be recorded while describing the event so that they can listen to the recording between sessions and further process the emotions and practice breathing techniques. It's also going to involve in vivo exposure. So this is going to be gradually approaching the trauma and other kinds of trauma reminders. So we're thinking about like situations, objects, etc. These kind of exposures are going to be safe. They're going to induce fear, and the client's going to want to try to avoid them. So the client's actually going to be confronting this feared stimuli outside of therapy. So they're going to be assigned homework to go to these places, interact with these events, and the therapist and patient together are going to identify a range of possible stimuli and in situations connected to the traumatic fear. So these are like specific people, specific places. The client and the therapist are going to agree to which stimuli they're going to confront as part of in vivo exposure and devise a plan to do so between sessions. The patient is also going to be encouraged to challenge themselves to do so in a gradual fashion so as to experience some success in confronting the stimuli and coping with emotion over time. This is not going to be something where it's like, oh, I was sexually assaulted by this person, so I need to go confront this person. That's not what we're talking about here. We're talking about trying to help the individual gradually expose themselves within reason, in a safe environment, in a safe fashion, in a well thought out manner to the feared stimuli. This right here, this kind of treatment is another form of CBT and is used for adults suffering from post-traumatic stress disorder. This is based on emotional processing therapy. So this is going to be a very brief treatment. It involves usually around 9 to 12 sessions. These sessions are anywhere from 60 to 90 minutes in length, and they're conducted once or twice a week. The first 2 sessions are going to be devoted to information gathering, explanation of the treatment rationale, treatment planning, and breathing retraining. So during the remaining sessions, the clients are going to relive their traumatic experiences by imagining them as vividly as possible and describing them aloud in the present tense. This is the imaginal exposure component. So this is going to include their thoughts, feelings, and physical sensations at the time. Now, these narratives are recorded, like we talked about before, so that way the client can go home and listen to them as homework. Now, they're also going to be able to confront, through their homework, these different situations and the stimuli that trigger the distressing memories and thoughts that have been avoided in the past. This is the imaginal exposure. So the homework assignments and imaginal exposure are going to be reviewed in session. The clients are going to discuss their emotions, cognitions, and other responses to the activity. And the therapist is going to use non-directive statements to validate and normalize the client's experiences and reactions. So the exposure exercises are intended to teach clients that trauma memories are in fact not harmful and that they can cope with them. And the in-session discussion seeks to help clients change any kind of erroneous beliefs about trauma and reevaluate their feelings about it. So ultimately, this method is aimed at habituating clients to the traumatic events so that it no longer invokes excessive anxiety, fear, and other distressing emotions that the traumatic memories previously did. So we talked about stress inoculation training and prolonged exposure therapy. So Pho et al. Compared these 2 different forms of therapy to each other, try to figure out which one was better for post-traumatic stress disorder. So after conducting the study and comparing the outcomes of clients, Pho et al. Discovered that SIT showed the best short-term results and PE showed longer lasting effects at follow-up. So some people wondered what might be a cause of this difference, like why is PET better in the long term, but SIT is better in the short term? Researchers believed that SIT addresses symptoms, but PET addresses the underlying fear patterns associated with these symptoms. So here is another treatment for PTSD. This is cognitive processing therapy. So this is actually another form of CBT. As you're seeing here, CBT is very important when it comes to PTSD treatment. So this form of CBT training was originally used for victims of rape or sexual trauma, and it was later applied to individuals with post-traumatic stress disorder with a variety of trauma. So CPT, cognitive processing therapy, this emphasizes cognitive strategies to help people alter erroneous thinking that has emerged because of a traumatic event. So practitioners want to work with clients on the false beliefs that the world is no longer safe. Well, they might also want to work on the false beliefs that the individual is incompetent because they let the traumatic event happen to them, which happens sometimes. So what you want to do here, you want to work on things like self-blaming thoughts. You want to try to restructure the meaning of the event. You want to try to restructure the implications of the trauma on the individual's lives. And you want to rebuild feelings of safety, trust, power, control, self-esteem, and intimacy with the individual to help them live a more complete life. This kind of treatment also has an exposure element. Exposure element is going to help the client to achieve these goals. So let's look at how this might work. So you have an individual who experienced a trauma. They were robbed at gunpoint late at night. So the client might think that it is my fault that I was robbed at gunpoint late at night. This might cause them to feel angry, guilty, sad, and ashamed. Now, the client has evidence for this. The evidence the client has is, I knew it was a bad neighborhood. The client might also say, I knew I shouldn't have been alone that late. The client might also say that I shouldn't have had that much money on me. So they're blaming themselves for what happened to them. Now, what you want to do is help the client to develop evidence against those feelings. So the client might develop this new response, which is I didn't make the person do it. I can't control anyone. And even things that I was in control of might have made it more likely, but it didn't cause it. So this is different from blaming yourself. This is saying, sure, walking down the street alone at night might be a bad idea if I'm in the wrong neighborhood with a lot of money on me, but I didn't cause this to happen to me. It's not my responsibility that this happened to me. Through this retraining of thoughts, you can see that there's you have the client understand that there's many factors that actually contributed to this armed robbery. And now that you've helped them to restructure their thoughts, they're able to feel better about themselves, carry more agency, more self-esteem, feel more in control of their life, and work on some of these other negative feelings that they've been experiencing due to the trauma. So that's cognitive processing therapy from Resnick et al., 2001. All right, so right over here, we have a video on eye movement desensitization and reprocessing therapy. This is a treatment that was developed to treat PTSD. We're going to watch this video and then we'll talk about it.
Do you struggle with anxiety, depression, or stress? There's a therapy being used right here in Northeast Wisconsin that may help. While some patients think it's odd at first, by the end of their treatments, they call it a lifesaver. It's tonight's NBC 26 special assignment. Chris Elliott had a traumatic childhood.
My father was an alcoholic and an abusive parent.
The man who was supposed to protect his family instead became their worst enemy, spewing hurtful words.
A lot of times that I was no good, that I would never amount to anything.
But the physical abuse bothered him most, especially one night when Chris was 7.
And when he was on top of the steps where my bedroom was, and he was holding on to my mother about to throw her down the steps. So I was trapped inside that bedroom trying to escape, get away from the whole situation.
That awful night haunted him into adulthood.
I would actually be afraid of falling asleep because I was afraid of my dreams, afraid of losing control.
Even afraid of the bedroom he shared with his wife. Panic attacks also interfered with his job. After trying prescription medication, he eventually turned to clinical psychotherapist Carmen Collier for help at New Wellness Associates in Green Bay.
So focus on the incident and the words, I'm better than that, and follow my fingers.
Chris began EMDR therapy, which stands for eye movement desensitization and reprocessing.
EMDR therapy stimulates the eye movements that happen during REM sleep,
which is the brain's natural restorative healing process that can be used while a person's awake to help reprocess traumatic experiences.
During therapy, patients follow Carmen's fingers and answer a series of questions about negative memories.
It is not hypnosis, and a person's always in control. They can stop at any time.
Carmen says EMDR therapy can help military members with post-traumatic stress disorder, people with anxiety, depression, pain, self-esteem issues, and even phobias, like a woman who developed an intense fear of tornadoes after severe storms slammed Kaukauna.
And anytime there was a weather warning anywhere around the world, she would hide in the basement with her pets. And so I worked with her and relieved her of that.
The sessions last about 60 to 90 minutes.
A lot of times when I'm doing EMDR with people, I can visibly see the anxiety leave their body.
Carmen says patients experience relief in as little as 1 to 3 sessions. And for more complex trauma, it can take a dozen or more treatments.
Good. Take a breath.
Chris felt better after 7 sessions.
I have not had any panic attacks. I don't have the anxiety.
Chris has written a book about overcoming your past to become a better you. Teaching leadership development at local high schools has also been therapeutic. But Chris says EMDR therapy was the final important step to fully heal.
I sleep just fine. I'm not afraid of my bedroom anymore. I feel like I have my life back.
Carmen says there are 19 studies that prove EMDR is a valid and a reliable form of therapy. The treatment started back in 1987. To date, it has helped more than 1 million people, and it is approved by most insurance companies. To learn more about EMDR, go to our website, NBC26.com, and click on this story.
All right, so the eye movement desensitization and reprocessing therapy, this is going to be a form of exposure therapy with a strong cognitive component. This is also going to be accompanied with that eye movement they were talking about in the news report there. So the way that EMDR works is that the patients imagine the scene of whatever happened to trauma. They want to focus on the accompanying cognition and arousal that comes with the trauma. So what we're going to do is the therapist is going to go like this with the finger. The client's going to follow the therapist's finger. It's moving like this. This sequence is repeated until anxiety is decreased, and then the patients generate positive thought associated with the scene while moving their eyes. And so there is a theory of advanced information processing that was developed by F. Shapiro, which states that there are unprocessed memories that contain emotions, thoughts, and beliefs and physical sensations associated with the trauma. Memories need to be triggered in order to be restored, because right now these memories store disturbing elements of the trauma into the PTSD, so they need to be re-experienced so you can reform those thoughts. So unlike other treatments that focus directly on altering emotions, thoughts, and responses resulting from traumatic experiences, EMDR therapy focuses directly on the memory itself and is intended to change the way that the memory is stored in the brain, thus reducing and eliminating the problematic symptoms. By focusing on the traumatic memory and simultaneously experiencing this bilateral stimulation, vividness and emotion of the memory are reduced. And then this treatment has been recommended for treating PTSD. So there are some issues with this treatment. So this is very controversial, and there's a few reasons why we'll go over. So this treatment is not based on any kind of scientific data. Now, research shows that this treatment is effective, but the eye movement component is actually irrelevant to this treatment. Independent researchers have found that you can replace this eye movement or just remove it, and there's no effect to the treatment. And so researchers believe that active ingredient of this therapy is the exposure and cognitive restructuring involved. Well, one of the reasons why this therapy is coming on fire is that Shapiro, who developed this treatment, has made a lot of money. So in order to provide EMDR therapy, the clinician has to pay $500 per course, and they must attend 2 courses in order to be certified in EMDR. That's $1,000 for Shapiro. So Shapiro actually developed this treatment because it helped them out with her own PTSD symptoms, but there's no theoretical basis for this treatment. And studies have actually shown some people who haven't responded to any other form of treatment have found success with EMDR, but the people conducting this research that found this success were actually people who had already paid for EMDR training. So these 19 studies talked about in this news report are individuals who paid that licensing fee and were invested in the outcome. And one of the things that some of you might remember from some of our office hours conversations or conversations over email is just because a study exists doesn't mean that a study proves anything. Remember, studies don't prove anything. Studies find evidence in support of something. So if you have a vested interest in this thing being supported so you can earn money, that calls into question the ethics of your findings or the veracity of your findings. So there might be a variety of different kinds of effects in play here. There could be a placebo effect, or the treatment might actually be effective. Now, does that mean that the outcomes are bad? No. I mean, if the client has good outcomes, then who cares? There's a variety of different ways of looking at it. EMDR might be a good thing, just like crystal therapy and equine therapy is a good thing. But when we're thinking about the ethics of clinical work and the way research goes, this is a good example of sometimes we are selling things to clients that might not be more beneficial. So that's the end of this lecture. So what I'll go ahead and suggest for you to do is if you have questions, send me an email, come to office hours. Yeah, that's it. So that's it for today. All right, talk to you later.